All right, folks. So today we are going to cover muscles of the head, neck, and face, as well as joints of the spine. So why don't we start there? The main joints that we're going to be looking at are the atlanto-occipital, the atlanto-axial, and the temporomandibular. So the first two joints, the atlanto-occipital refers to the joint between C1, the atlas, and the occiput above it. This is going to allow kind of rocking motions as well as a forward-backward movement. The atlanto-axial joint between the atlas, C1, and C2 beneath it form a pivot joint, which allows rotation around an axis. So that's what gives you the rotational movements. So these are both synovial joints. These are freely movable joints. Here we see kind of a second view of the two vertebrae. You'll see the transverse ligament, which wraps around the odontoid process on the posterior surface, just locks that thing into position. So we lock the peg into its groove so the top bone can't slip off. So we're locked in place. This allows the rotational movements. The third joint we're looking at is the temporomandibular joint between the temporal bone and the condyle of the mandible. This is another synovial joint. So here is C1, and from here you can start to get a sense of the way the entire skull is simply resting on those two superior articular facets. Your whole skull is just balanced on those two. Yeah. All right. Sorry, my app is being a little slow. Get it together. This app is just, it's being really touchy, guys. Sorry. There we go. Come on, dude. Temporomandibular joint. You've got the socket-like portion, which is up on the temporal bone. You've got the condyle of the mandible, which will fit into it. The general kind of movement this is going to try to allow is a swinging movement, which is actually opening the mandible. So when you open your jaw, it's actually more of a swinging movement. But we also can get lateral deviation from this joint, which is a very fancy word. It means it moves to the side. So think about like the barrel of a typewriter, like sliding to one side. Lateral deviation looks like this. And there you have it, folks. Okay, since we are moving on to the face and onto the neck, there are several areas where we will need to use extra caution. It does not mean that we can't massage these areas. This simply means there are structures that are very close to the surface that can either be sensitive or they're carrying something important like blood. So we want to be extra aware of them. The list of them are here. We're going to move on and start visiting these independently. The first is the carotid artery. The carotid is the primary artery that's heading up the neck that's bringing blood into the brain, head, neck, and face. So the carotid artery naturally is kind of important, and you really don't want to put pressure on it. This artery will originate from down behind the clavicles, and it will rise up on either side. On the right side of the body, this is my right over here, the common carotid originates from the brachiocephalic trunk. On the left, it comes from the aortic arch. So let's give ourselves a bit of a visual here. I add in some arteries and you'll see right off the rip. Let me get rid of this sternum so we can see where the heart is. All right. So there is the arch of the aorta. That's where all the blood is leaving the heart, going on out into the body to do blood stuff, you know. On the right side, we have the brachiocephalic trunk. This trunk's name tells you where its destination is. Brachio, referring to the arm. You've got that one that goes out to the right arm. And cephalic, cephal meaning to the head. So the brachiocephalic trunk on the right side branches to the arm and up the neck. There is where we get our right common carotid artery. The left common carotid, come on, there we go, branches directly off of the arch of the aorta. We can feel the pulse on the front of the neck, just medial to the SCM. So if you find your SCM muscle right in front of it, right about there, about halfway down, kind of next to your voice box, that's about where you're gonna feel for a pulse. You kind of push in there and you gotta get quiet. I can't be talking and doing this too, but if you press in, you will feel the pulse. Carotid artery. Another structure of note is the brachial plexus. I feel like we've mentioned this one once or twice before. This one will emerge from the transverse processes of C5 through T1. So we take the blood out, now we add in nerves. And all along through here, from those transverse processes of C5, or whatever it was, C5 through T1. All of these nerve bundles will start to come together somewhere near the upper shoulder, kind of superior to the clavicle. If I add in just a few muscles, kind of a layer at a time, we can start to see how these guys get threaded through the muscles. And there we have the anterior scalene. These are going to be lateral neck flexors as well as neck rotators. So when the head is held in a flexed position, like with forward head syndrome, these muscles are shortened. One of the key things to keep in mind, you guys, when muscles contract, they don't just get shorter, they also get thicker. And when they get thicker, the texture changes. They're not nice and supple and squishy. Now they get thick and firm. So when these two muscles contract, the anterior scalene and the middle scalene, they have the nerve plexus running right between them. So when they contract, they put direct pressure on the nerve bundle. We also can see this nerve bundle is passing, oops, wrong one, there, just posterior to pectoralis minor. So the anterior and middle scalene muscles in the neck and the pec minor muscle on the shoulder and chest, both of these muscles are capable of putting pressure on that nerve bundle that will lead to thoracic outlet syndrome. It's numbness and tingling and muscle weakness that goes all the way down the right arm. Good stuff so far. All right. The next structure is the temporal artery. This is the artery that is going to the temporalis muscle, which sits right over the top of your ear. If you put your finger right in front of your ear, just up above the ridge of the cheekbone, right where my fingertip is, you'll find a nice little dimple where your finger kind of wants to sit in, right there. If you apply a very, very light pressure, like just the weight of your finger, you'll feel the pulse from the temporal artery. I'll give you guys a few minutes. You got to be very gentle. Yeah, there it is. So the crappy thing about arteries, you guys, is there's like, I don't know, 4 million of them in the body, and they all have names. The cool thing about arteries is they're named based on where they're going, or like where they are. So when we see the temporal artery, it's going to the temporal bone, the temporal muscle. It's going in this area here. The occipital artery, same deal. It's going to the occipitalis muscle on the outside of the occipital bone. The ophthalmic artery, like an ophthalmologist checks your eyes, it's going to the eyes. Facial artery, I'll give you 5 guesses where that one's going. And the lingual artery, the root word ling or lingua means tongue. So that's where we get the root for the word language. It's the tongue of people. Fun fact. Facial artery, right there in the face. You can feel the pulse of the facial artery at the base of the mandible, just anterior to the masseter. So if you take about 2 or 3 fingers, place them right on the angle of your jaw, and now clench your jaw really tight. You'll feel the masseter kind of contracting. Use the bulge of that muscle to find its anterior border. And then just kind of rest your finger along the front side of the masseter, right near the base of the mandible. Very gentle pressure. Don't push too deeply. You'll push right through the artery, but you can feel a pulse. Don't use too much pressure. If you're really feeling the surface of the bone, you're pushing too hard. Just push through the little fat layer. You need a pressure equivalent to the weight, I would say, of just a couple of coins. Just enough to create a dimple in the skin. That's about all the pressure you need. Next up, the facial nerve. The facial nerve emerges from the cranium just anterior to the mastoid process. And then from there, it will spread across the face and the scalp. If you guys have taken nervous system and you remember your cranial nerve, the 12 pairs of cranial nerves, you remember the facial nerve. This is cranial nerve, oh gosh, 7, I believe. So we just want to be aware. There are very superficial nerves running in front of the face. So, no crazy firm pressure, right? Like don't use elbows on people's faces. Nice light pressure on the face. The vertebral artery is a structure that is protected by the cervical vertebrae all the way up. We will recall from bone anatomy, cervical vertebrae differ from other categories of vertebra, mainly because they had those transverse foramen, those holes along the side. The purpose is that the vertebral artery is threaded through those foramina like beads on a string. This artery passes from the heart up, held within the framework of those transverse processes, all the way up to the occiput, where they will then wrap posterior to the superior articulating facet of for the occipital bone. They come together and they shoot straight up through the foramen magnum and they go up into the brain. Therefore, when we are working on the neck, particularly for the carotid artery and for the vertebral artery, if you are using techniques which require a lot of pressure to be put on the neck, we want to work one side at a time. You do not want to put pressure on both sides at the same time, as you will cut off blood supply to the brain, and that would obviously be really bad. So really deep techniques like SCM stripping or work on the really deep neck flexors, we want to limit that work to one side at a time, and then make sure you give plenty of time, like a solid minute or so, for one side to really restore blood flow after you've been digging in at it. Other structures to be aware of throughout the neck and underneath the jaw are lymph nodes. Lymph nodes will generally be found fairly superficial to the surface. They will just feel like weird, squishy little, they're about the size of peas. They're really squishy. I would say almost like a really soft gummy bear, like they're really, really squishy. Usually you don't really feel many of them until they become inflamed. And that's what the doctor's feeling for when he comes around and feels all over your neck and stuff. He's feeling for any lymph nodes that are inflamed, classic sign of infection. Otherwise, you may be able to locate a lymph node or two, maybe down here towards the base of the neck. They will feel, again, very, very small, just like a small lump of kind of a squishy, it doesn't really hurt when you squeeze them. They're just kind of there. That's probably a lymph node. Now, the anterior and posterior triangles of the neck are well-known endangerment sites to massage therapists. The anterior triangle is bordered by the base of the mandible, the midline, and the medial border of the SCM muscle. So this is the anterior triangle. This is where you can feel the pulse of the carotid artery. That's pretty much specifically why this is an endangerment site. But also right next to the carotid artery is the primary vein that is draining all of the blood from the head and the brain and returning it to the heart. That is the jugular vein. You also have the trachea and the thyroid and the hyoid bone and submandibular salivary glands, as well as all those lymph nodes. So we want to use extra caution when working directly on the front of the neck. Anterior triangle. Second is the posterior triangle, which is located right here between the posterior border of SCM and the anterior border of the upper trapezius and a little bit of the clavicle. The posterior triangle is rather small. It just kind of sits right about here. It's called posterior because it's posterior to the anterior triangle, not because it's on the back of the body. It's still on the front right here. We have the external jugular vein, we have the brachial plexus, we have the subclavian artery, which is another important artery, as well as cervical lymph nodes located down here. Lots of delicate structures. Again, just need to be careful working in this area. Doesn't mean you can't touch it, just means, you know, maybe don't throw bows at it. Elbows for the uninitiated. Another super cool structure is the parotid gland. This is your primary salivary gland, superficial to the masseter, and it's about 2 fingers wide, about 2 fingers long, and it sits right about there, just underneath the jaw, or the, just underneath the cheekbone, down to the base of the jaw, and about 2 fingers wide. Sitting right there on the outside, the salivary gland produces saliva. Who would have guessed? Fun fact. Very recently, and I mean like 2018, I believe, it was widely believed that we had 6 salivary glands, 3 on each side. They were doing some research on cancer patients for something totally unrelated. Cancer patients have to go through chemotherapy, and chemotherapy causes really dry mouth. So they were doing research into salivary glands to try to see if they could make a medicine that would help with dry mouth for chemotherapy patients. Follow me. So one of the things that they were doing was they were trying to get really good images of their salivary glands. So they injected them with a dye, kind of like when you've seen they'll do like the barium drink, right? You swallow barium and then they get a perfect image of your intestines as the liquid finds its way through your intestines. They did the same kind of thing with the parotid glands. So they had them drink this dye that would react strongly with salivary gland tissue, and then they took these scans of their face so they could spot exactly where these things are. They found a whole nother pair of salivary glands, like just recently. We've always thought there were 3 pairs. Turns out there are 4. The 4th pair is deep in the skull, wrapped around the eustachian tubes. Those are the tubes that go from your ears down to the back of your throat. So when you're on an airplane or something, you're trying to get your ears to equalize, you plug your nose and blow, and it like pushes the air out through your ears, it's through those tubes. And those tubes have wrapped around them the fourth pair of salivary glands. That fun fact is free. You're welcome. That's just my gift from me to you. All right. So those are the structures of interest, the things that we want to be careful of, be cautious of, be aware of while we move around the neck. Let's talk about movements. So for the mandible, we have elevation and depression. So we can depress the mandible and we can elevate the mandible. We can protract the mandible. Think about an underbite where we push the mandible forward. And we can also retract where we pull the mandible in. Think of an overbite. So we retract the mandible like this. We also have lateral deviation, which we talked about earlier. Now, the key point here is all of these actions are used in chewing, right? So if you really think about chewing your food, it's not just a straight up and down process, right? It's a circular kind of grinding motion where the jaws move in circles around each other. They crunch like this. They also grind like this. So we're really like a mortar and pestle, just trying to tear and rip the food into tiny little pieces. So we need the jaw to be a little more mobile than just a clean up and down. For the neck, we've mentioned neck movements before. We have flexion, we have extension, we have lateral flexion, and we have rotation. Cool. Some of the major conditions that we'll be working with when we're working in this area, TMJD, temporomandibular joint dysfunction, or temporomandibular joint syndrome, both refer to the same thing. It's a dysfunction of the joint, usually caused by degradation, overuse, misuse. Maybe the joint is misaligned, so the joint starts to wear out unevenly. You ever seen tires that go bad and one edge of the tire is like bald, but the other side is fine? Think about something like that. If the jaw isn't sitting on its hinges properly, then one side gets worn out, the other side doesn't get used enough. So now there's too much movement on one side of the joint. The cartilage will start to wear away. So then the cartilage disc gets very thin. Eventually it gets to be bone on bone. Then it really hurts to open your mouth and move and chew and talk and do all that, little things like that. Thoracic outlet syndrome, we've mentioned earlier. It's the nerve compression, either caused by the anterior and middle scalene or pec minor. So this will lead to thoracic outlet syndrome, which leads to numbness and tingling all down the arm. This condition is very common in people whose professions require them to raise their arms over their head a lot. So think about mechanics or electricians or landscapers, right? They got to cut tree branches and stuff down. So they're contracting these muscles as they raise the shoulders overhead. They stay like this for 8 hours a day, times 40 hours a week, times, week after month after year. And then the next thing you know, they can't feel their hands. Headaches. Do we need to talk about tension headaches and why all these muscles wrapped around the head cause headaches? Are we clear on this principle? Cool. And forward head posture. Forward head is caused by tight flexors. So these guys pull down on the head, causing it to be held forward of its kind of anatomical neutral position. This causes numbness and tingling in the arms and shoulder blades because, again, all these muscles are either pulled short and tight, or the muscles on the back are going to be stretched long and they're going to be stretch weakened. All right. Next up, we have the muscles for today. I just want to do a quick temperature check. How's everybody feeling about our material so far? Cool, cool. Cool, cool. All right. Alrighty, first muscle for today is splenius capitis. The name splenius comes from a word, it means bandage. These muscles are kind of strip-like muscles, so they look kind of like bandages. Capitis tells you where the muscle inserts. Capitis, like where you wear your cap, inserts on the skull. So it begins on the inferior portion of the ligamentum nuchae. That's the fin-like ligament that runs through the back of the cervical spine, connecting the spinous processes, as well as the spinous processes of C7 through T4. So base of the neck and part of the upper back. It inserts on the mastoid process of the temporal bone and the lateral portion of the superior nuchal line. So let's come back to our skeleton man. We'll get a good sense of where this muscle sits. As always, we've got to get rid of trapezius. And there sits splenius capitis. So we see it starts here. It would be attached to the ligamentum nuchae. The ligamentum is just not shown here, but it would be there. Spinous processes of C7 through T4. And the muscle comes up to insert at the mastoid process and the lateral portion of the superior nuchal line. So looking at this muscle, we would see that if both sides contract together, because the muscle is posterior, it's going to cause extension. If one side contracts, it will cause lateral flexion. So the origin is on the spine, the insertion is behind the ear. It will either pull us into lateral flexion or bilaterally, it will pull us into extension. We also have ipsilateral rotation. So one side contracts, we rotate to the same side. Here we will watch rotation. If my app decides to catch up with me, apparently I'm moving way too fast for it. So by pulling the mastoid closer towards the spine, the head rotates. Ipsilateral rotation. Next, we have extension and hyperextension. And lastly, lateral flexion.
Would you show where the ligamentum nuchae?
Nuchae. Yes.
Nuchae, okay.
This is the ligamentum nuchae. It is a dense strip of ligament that runs from the midpoint on the occiput, kind of along its midline, and it connects the spinous processes down through all cervical vertebrae. And that serves as kind of the anchoring point. So when they say that the muscle attaches to this thing, it plugs straight in and just straight to it.
Okay.
So we'll
And it
see.
starts on the nuchal line.
At the external occipital protuberance. The nuchal lines go out transversely, whereas this thing passes sagittally.
Okay. Thank you.
You're very welcome. Yeah, when I isolate the muscle, it takes everything away except the muscle. So I would have to. But you see where it is. You see where it is. Okay. So splenius capitis. Capitis, like where you wear your cap. It's on your head. This muscle inserts on the skull. Mastoid process, lateral third of the nuchal line. The next muscle is splenius cervicis. Cervicis, like cervical, like the neck. This one does not hit the skull. This one inserts on the neck, on the cervical spine. Origin, spinous processes of T3 through T6, so mid-back. Insertion, transverse processes of C1 through C3. So this guy's origin is lower than its insertion. So when it contracts, it will reach up to the cervical spine and pull down. One side will create lateral flexion or ipsilateral rotation. Both sides create extension. This muscle is also called splenius coli. That's what it's called here on this app, but this is in fact the same muscle as the splenius cervicis. So spinous processes T3 through T6, insertion, transverse processes of C1 through C3. Because the muscle crosses posterior side, that tells me extension. We also see it inserts kind of on the lateral side on the transverse processes. So that's cluing me in. It's going to be a lateral flexor. And when you look at the muscle, it looks like it runs kind of at an angle. Muscles that run at an angle will tend to rotate something. So that muscle is going to cause ipsilateral rotation. Good stuff? Good stuff.
Basically, these two muscles are doing the same movements, right?
They are doing similar movements, yes. Yes. Ipsilateral rotation, lateral flexion, extension. So what does this tell me if they're doing the same actions? What does that tell me?
They're complete synergists.
They're complete
They are
synergists.
synergists, like
Very good.
yeah.
Very good. They are the Robin to each other's Batman. They're the Teres Major to my latissimus dorsi.
Okay.
So there's a very lovely 1990s textbook illustration of these muscles. Yeah, that's them. All right, splenius capitis and splenius cervicis. Both of these are kind of bandage-shaped muscles, but one stops at the neck, that's the cervicis. One goes all the way to the skull, that's the capitis. The next muscle we're going to look at is the sternocleidomastoid. I love this muscle. I love this muscle. Ooh, it's a good one. All right, this is another weirdo whose origin is below its insertion. So the origin starts on the manubrium of the sternum and the medial, I would say medial fourth or so of the clavicle. So two distinct origins. This muscle has two distinct fibers, which will join together about midway up the neck to become a single muscle inserting at the mastoid process. Hence the muscle's name, sternocleidomastoid. We often simply call this muscle the SCM. So as we've learned with muscles before, sternocleidomastoid crosses the neck on the anterior side. That tells me flexion. Since it's paired, I've got one on both sides. That's also cluing me in lateral flexion, right? Lateral flexion if they contract one at a time, flexion if they contract bilaterally. But this muscle also runs at an angle, and that tells me rotation. This muscle is going to be a contralateral rotator. So when your left SCM contracts, the head rotates to the right. The left contracts and causes rotation to the opposite side. Contralateral rotation. And again, if this is kind of making your brain work overtime, remember guys, we think of muscles contracting. What you're really doing is pulling the insertion toward the origin. And since we're looking at these kinds of joints, the spine we know is a pivot joint, so the spine is allowed to rotate. So pulling the mastoid towards the sternum can look like flexion, but it can also look like rotation. Bilaterally, we get flexion when they both pull down. And on one side, particularly the clavicular fibers, we get lateral flexion. Such a good muscle, such a good muscle. So sternocleidomastoid's origin, top of the manubrium and medial third or so of the clavicle. Insertion, mastoid process. You say lateral portion of the superior nuchal line, but mastoid process pretty much nails it. So one side, we've got lateral flexion and contralateral rotation. Bilateral, we've got neck flexion. We also have, if we pull up on the origin, we can get elevation of the rib cage during inhalation. So this can be a breathing muscle, which we just kind of latch onto the sternum and pull up. SCM, good stuff. Next muscle, scalenes. Oh, we remember these guys. We just talked about these folks. Scalenes. Origin is transverse processes of C2 through C7. So transverse processes of all the cervical vertebrae except the top one. They insert your anterior and middle scalenes, insert on the first rib. The posterior scalene inserts on the second rib. Will this do? Yeah, this does just the middle. Anterior, posterior, rib, rib. So anterior and middle scalene will insert on the first rib. Posterior scalene inserts on the second rib. All of these muscles originate at the transverse processes of C1 through C7. I'm sorry, C2 through C7. No, I didn't mean to do that. I'm trying to dig the others out, but gets a little tedious. But there we can see these muscles sitting right on the lateral side of the neck. Taking a look at those guys, just a quick glance, sitting as they are on the lateral side of the neck. First thing I'm thinking, lateral flexion. That's first thought. They don't really look like they're in much of a position to help with rotation. Any way they pull, it's basically going to be pulling the neck down towards the shoulder. But we will get a little bit of rotational assistance. So these guys will be Robins, not Batman, for movements like rotation. When you think about rotation, you think of larger muscles like upper trapezius, SCM, splenius capitis, splenius cervicis, guys like that. These tiny little scalene muscles, they're not going to be the prime mover of nothing. Unilaterally, we get lateral flexion and contralateral rotation. Bilaterally, we get neck flexion and assistance with rib elevation. Good stuff. All right. After the scalenes come the suboccipitals. Suboccipitals are independent muscles, so there are actually 8 of them. There are 4 pairs of muscles. So there's 4 muscles on one side and their counterparts on the other. We often just call them together the suboccipitals or the suboccipitalis. But I would just like to point out it's not one single muscle, it's a small group of muscles. So generally, each independent muscle, we are not worried about where its origin or insertion is. You're talking about 8 muscles all fitting into a space like this big. So we'll just say they start on C1 and C2, they insert on the occiput. So this tells you a clue as to where they are, right? C1, C2 to the occiput. You're really looking at a very small area for these muscles. Together, they kind of rock and tilt the head back into extension. They assist with ipsilateral rotation, and they assist with lateral flexion. So here is what I mean. You are looking at oblique capitis superior, oblique capitis inferior, and rectus capitis posterior minor, rectus capitis posterior major. 4 tiny muscles. And there's a left and a right. Let's not focus on all of that. Let's just look at the suboccipitals as a group. So we're going to come back to our little skeleton guy. Give me a second because I got to get rid of a whole bunch of stuff. And there are your suboccipitals. So just on one, whoa. This app is really touchy for me today. I'm sorry. So we have 1, rectus capitis posterior minor. We have 2, that's rectus capitis posterior major. Number 3, oblique capitis superior. And number 4, oblique capitis inferior. I do not expect you guys to learn the names of these muscles. Just saying, that's not, we're just gonna call these the suboccipitals. Cool? Everybody cool with that? Cool. So these are your suboccipitals. I can't explode them out so we get a little bit better look at them, but there's not really a whole lot to see. They're very small muscles. But we can watch as these muscles work together to kind of work the head back into extension. And we can watch them assist with rotation. Well, we watch them assist the best they can since the app keeps putting all these bigger muscles on top. I'm not bitter.
So they don't like do a smooth head extension?
They will assist with making the head extension smoother.
Okay.
Does that, if you follow me? Larger
Yeah,
muscles
they're
will
just-
like do the task of pulling the head back. These guys are firing in tiny amounts just to make sure that the movement stays nice and fluid.
Okay.
They'll also contract in order to keep the movement from happening too quickly. So they will structurally support so that we don't go like jerking the head
like
around.
whip our head, yeah. Okay.
Yes. And so when you think about something like whiplash, right, where the
Mhm.
head is violently pulled one side to the other, whiplash is a very complex injury that involves injury to several different tissues. Suboccipitals are one of the tissues that are damaged because they get suddenly pulled and overstretched. And these are really, really small muscles. So it doesn't take a lot of force to overstretch these tiny little muscles, right? It's not like a bicep where it'll take hundreds of pounds to damage that muscle. These little guys can only take tens of pounds. And your 12-pound head go whipping around side to side really fast, it will feel like several dozen pounds are being put on these muscles.
Okay. Awesome.
All right. The next muscle is the masseter, and this is where we make a note. You do not need muscle cards for face muscles. So no, don't have to worry about making little cards for the muscles on the face. Many people have probably been told in their lives that the strongest muscle in the body relative to size is the tongue. Has anyone ever been told that before? Strongest muscle is the tongue? Yeah. That is not actually true. The tongue is not a muscle. The tongue is 8 different muscles. So knowing what we know now about muscles, right? We know the only trick muscles have up their sleeve is a pull. That's all they do. They just pull and then relax. So if I were able to move my tongue like this, that means some muscle over here is pulling it that way, right? So I need a different muscle on the other side to pull it back. So in order to move the tongue in as many ways as we can move our tongues, right? You can flip it back, you can flip it down, one side to the other, curl it up. You need lots of different muscles positioned around that tongue to pull it in all those different directions. There are 8 muscles in the tongue. So the tongue isn't a muscle, so we can't really count the tongue as the strongest muscle in the body because it's multiple muscles. So if we were to properly say, relative to size, which is the strongest muscle in the body, it would be the masseter. This muscle sits right here. You can feel it when you clench your jaw over and over and over and feel around. You'll feel this muscle begins along the zygomatic arch, right on the underside of your cheekbone, and it travels all the way down to the angle and base of the mandible. When this muscle contracts with its full force, its job is to elevate the mandible or to close the mouth. So when the masseter contracts fully, it can shorten with 150 pounds of biting force. That is enough to bite off a finger at the joint. Like you could literally bite off one of your fingers. That is a incredibly strong muscle for its size. In terms of just straight up raw power, what is the strongest muscle? Gluteus maximus, by far, by several orders of magnitude. Gluteus maximus is most likely the strongest muscle on your body. However, the gluteus maximus is, well, Maximus, it's huge. It's an enormous, dense, massive muscle. So when we balance out for size ratios and things like that, man, it's no question, masseter by far. Why is this app so slow today? And there is masseter. From the zygomatic arch to the ramus of the mandible. Its primary job is mandible elevation, so it closes the mouth, but it will also, if you notice those fibers moving at an angle, it will also assist with protraction, so moving the jaw forward. And this will only show me elevation, so I can show you the jaw closing. But pulling its insertion towards its origin, those slanted fibers will look like they straighten, so the jaw moves anteriorly. Masseter. Such a fascinating muscle. All right, temporalis. The temporalis muscle. You ever seen a bald guy chewing? You ever seen a bald guy chewing? And you see that muscle way up here in his head, like going all crazy? That's the one. Temporalis originates along the temporal fascia and the temporal fossa, so the connective tissue and the depression on the bone, fossa and fascia, all the way up here. Insertion, cornoid process, and the anterior edge of the ramus of the mandible. There is temporalis, and there is its insertion, right on the top tip of that shark fin-like projection. The origin is above, the insertion is below. So when this muscle contracts, it will pull up on the mandible. This also assists with elevation of the mandible or closing the mouth. But we can also go one more. Looking at the direction of those fibers, particularly those horizontal fibers, we can also pull backwards on the mandible, so which will help with retraction of the mandible, making, interestingly enough, making this muscle both a synergist to the masseter for elevation, but also an antagonist because one protracts and the other retracts. So we've got this really interesting, like, you know, like Robin goes rogue sort of thing. Temporal. All right. So guys, any questions so far? Anything that's unclear? Anything you want me to explain again? Go back over. We've covered a lot today. We talked about the joints of the neck. We looked at the endangerment sites and areas of caution for the neck, head, and face, and what structures are within those endangerment sites. We covered 5 major muscles, as well as 2 face muscles. We talked about their origins, insertions, and actions. Any questions?
So we just need 5 muscle cards, right? Because it's splenus capitis, splenus cervicis, SCM.
Sternocleidomastoid, scalenes, and suboccipitals. We're doing all the S's today.
Okay. And scalings on one card and suboccipitals.
One card. Scalene, yeah. Treat the scalenes as a group. It's a group of muscles.
Okay.
I mean, of course, there's an anterior, middle, and posterior, but those can go on one card. Suboccipitals, those can go on one card. The suboccipitals. Don't worry about naming each individual one. Just focus on what they are, where they are, and what they do.
Is there a study guide for the midterm next week?
It should unlock itself on Moodle. Let me double check right now. Thank you for reminding me.
You're welcome. Because I saw a link to the midterm, but not to a study guide. So
Yeah. Kines Upper Midterm Review is now on Moodle. As of right now, it's there.
thank you.
You're welcome. Okay, since we're here, let me I'm trying to figure out how to make myself the host again so I can share my other screen. There we go. Cool. All right, you guys should be able to see my other computer screen. Here is the midterm review. This is posted on Moodle, so you guys have it. It's right there for you. But midterm will be 30 questions, 13 multiple choice, 6 fill-in, 1 true false.
Do you mean 16 fill-in?
Yes, sorry, thanks. I can't see numbers apparently today. 13 multiple choice, 16 fill-in, 1 true false. Thank you. A third of the questions are from today's lecture, week 4. So this stuff, make sure you know this stuff. Study topics: origin, insertion, action, and lengthening. So the action is what it does when it shortens. The opposite action is what it does when it lengthens. So if a muscle is a flexor, it does that when it shortens. When it lengthens, it will extend. The muscle isn't activating, it's being stretched. Synergists, agonists, and antagonists. We've talked about different types of muscle contractions: isometric, concentric, eccentric. Make sure we know those. The bones and bony landmarks and the joints that we've covered, make sure we know the names and the kind of joint and what kind of movement they do. Sites of caution. What is it? Why is it there? Like, what's the deal? Brachial plexus. What's the temporal artery? Where's the carotid artery? Like, why are they important? What are these structures? And what structures are creating the impingement on them? So brachial plexus, what puts pressure on the brachial plexus? We talked about 2 things so far. Considerations: shoulder dislocation, shoulder separation. I think those questions on there were pretty basic. So do we know what shoulder dislocation is? In a shoulder dislocation, which 2 bones have become dislocated? Like that kind of thing. So when the shoulder becomes dislocated, it's the glenohumeral joint. So it's the scapula and the humerus that become dislocated. So there's your study guide posted for you guys on Moodle.
What's scapulohumeral rhythm?
So this was something we looked at in last week's slideshow. Scapulohumeral rhythm describes the difference in motion between the humerus when it's abducting and the scapula when it starts to upwardly rotate. So
like describing 2 different movements.
yes, the movement of the humerus and the movement of the scapula independently. Scapulohumeral rhythm, also known as glenohumeral rhythm, is the kinematic interaction between the scapula and humerus. In relation to the humerus and the glenohumeral joint as a means for shoulder mobility, the standard ratio is often recognized as 2 to 1, which means for every 2 degrees the humerus moves, the scapula moves 1 degree.
Okay.
Again, we didn't spend a whole lot of time on this. This is just, it's more about knowing the principle than like we don't need to know about joint angles or anything. But that's what we're saying is if you look at the humerus versus the scapula, as the humerus moves into abduction, the scapula also begins to rotate. The ratio of those movements is 2 to 1. 2 degrees for the humerus versus 1 degree for the scapula. Alrighty, my friends, this study guide is posted on Moodle. Don't forget the quizzes. Any other questions? Anything else we need to talk about?
I can find
then.
the midterm quiz. I just can see it.
You may need to pull it up on a computer. It may be better for you, but the midterm is under week 5.
Ah, okay.
And it's called midterm. Can't miss it.
So, but it's not for this week, right? It's next one.
Next week.
Just next week. Okay. Just
Next
to
week.
be sure. Okay. Thank you. All right.
Yeah, the quiz opens tomorrow and it is due. That's not right. Closes Thursday, October 20th. No, let me change this. It's in week 5. We are currently in week 4. So I don't want this to close the 21st. I want this to close next week, the 28th. This is due next week before class. It closes at 2:30. So not this week, not like the day after tomorrow. Next week, you guys have like a week and a half.
Okay.
But it is due before you walk into class next week.
Okay. Thank you.
Of course. Emily, thank you for getting me on this topic of midterms.
You're welcome.
All right. If there's nothing else, you guys, we've already gone over our hour by just a little bit. As soon as this recording is ready, I'll get it posted onto Moodle as quick as I can. If you guys come up with any questions while you're studying, jot them down in your notebook, bring them to me on Thursday. We'll be happy to answer them. Just like we've done before, hands-on on Thursday is going to be a lot of moving around on a table and drawing out muscles and whatnot. So come prepared, and I will see you all on Thursday.
Thank you.
Thank
pleasure.
you.
Bye.
See you Thursday.
Bye.
See you then.
Bye-bye, everybody.